Hi, Carsten. Great to meet you
Hi,
again.
nice to meet you too.
I'm honored to be sharing this interview stage with you. My name is Gok Ratnarajan. I'm a glaucoma and cataract surgeon from East Grinstead in the UK. I work in the Queen Victoria Hospital and the director of the Innovation Eye Clinic.
And my name is Carsten Klabe, working and living in Düsseldorf, Germany, working in a private practice, Brierheimer Klabe eye surgery. I'm a glaucoma specialist as well as cataract and vitreoretinal trained surgeon.
So I thought maybe, Carsten, this is just a chat about our experience with MINIject. I haven't got a huge amount of experience. I've done about between 30 to 40 cases, so certainly over the initial learning phase. How much experience have you had with the MINIject?
So we doing the MINIject now since around 3 years. We were some of the early adopters. Yeah, we reached nearly 100 cases. I was thinking about the supracoidal approach all the time because we see the results with angle-based surgery approaches, and the IOP lowering effect is, because of obvious reasons, limited. The alternative is a bleb surgery. And there was a space in between, and that was the supraciliar space, in my opinion.
I was quite comfortable with the supracoidal space. I'd used devices in that space before, but I think the size of the implant made me a little bit hesitant. Then I would speak to people like yourself who were talking about the safety and the good results, and then I started.
It is more challenging to that what we've done before with angle surgery or with reaching the supracoidal space. Due to the size, due to the material itself, it's very soft, and so the implantation procedure is different to that what we've known before. We've modified the surgical technique a little bit, but now I feel really safe with doing a MINIject implantation.
So, Carsten, I think a lot of people see this as a last-ditch attempt before a bleb surgery or for patients with refractory glaucoma. Where do you sort of see?
So absolutely disagree. What we've seen, not only in the trials which were published, but in real life, that the IOP lowering potential of the MINIject procedure is higher compared to angle-based or Schlemm's canal-based surgery. If I'm aiming for a lower pressure or my baseline pressure is higher, I'm going for a MINIject in a very early stage. It's not the last attempt before a bleb surgery.
So most of my experience has been as a standalone in pseudophakic patients. I've done a few combined. What's your experience combined with cataract surgery?
So same on me. I started with standalone, and the vast majority of my cases are still standalone. I had a couple of concerns for combined surgery. So what happens? Is there a shift on refraction? We know with previous devices there were a myopic shift, especially in combined procedures, but I've never seen this with a MINIject. So might be due to the different design, to the shortness of this, which allows the ciliary muscle to stay on place and there will be no movement. And that's why I feel safe with combined procedures. I'm doing more and more combined procedures. How about your surgical approach now?
Even over the learning curve, I've picked up lots of tips and tricks from the team at iStar and also fellow surgeons. A few of the biggest tips that I've worked out is increased illumination, because you've got the green marker, which is your sort of guide, and you want to have a good visibility of that during the implantation. So generally during phaco, I like to have low illumination to keep the patient comfortable, but during the MINIject, I will increase that to 50, even 60% sometimes.
Wow.
Another thing that I like to do is we, as MIG surgeons, we are teaching our fellows and trainees to have that perfect on-fast view. But actually for MINIject, you want to have that slightly top-down view, because if you think about the planes that you're working in, you're going there. If you have the top-down view, then you're not going to have the ergonomics to get into the plane that you want.
It could be challenging. You are absolutely right. So, and how about opening the supraciliary space? Do you use an additional approach or an additional instrument?
For me, using the spatula, iris spatula, just to open up that cleft and open up that supracoidal space. For me, I like that, because then when I have the device, which is obviously larger than an iris spatula, the initial resistance is overcome by a small device, firm device that is much more controlled than trying to do that with something larger. That's simple physics. Once that resistance is overcome, then it slides in like a hot knife through butter. And that's what you want to be feeling.
We know from the advanced glaucoma trials that the lower pressure is better? Or do we learn lessons with the introduction of MIGs that the vast majority of our patients with a mild to moderate are fine with a higher pressure. So where is your goal for IOP lowering in different patients?
There's two components. One, you've got the patient. Of course, we know that MINIject is safe, but if someone is very risk averse, you may think that actually a trabecular bypass may be the way forward. But I think that mindset is changing. The other thing is the surgeons. Trabecular bypass surgery has been around for a lot longer. So it's almost a bit of a knee-jerk reaction that's our go-to. So I think it's going to be something that's changing with more and more anecdotal evidence from the likes of yourselves, and obviously the published thing that actually that the go-to could well be the suprachoroidal space at the time of cataract surgery. Because ultimately, we know that the lower we can get the pressure, the better chance we have of controlling the disease. So why should a new surgeon start MINIject? It's a new space. The suprachoroidal space has a great potential to lower the intraocular pressure. Of course, we have a lot of options in the trabecular bypass part of glaucoma surgery, as well as the bleb surgery. But the suprachoroidal space can often be a bridge between the two. If the surgery works well, you have the potential to get very good pressure reduction off all medication, which is a strong driver for both the surgeon and the patient.
There is still a gap between standard mix approaches and bleb surgery, and we can fill this gap with the MINIject perfectly because the low IOP lowering potential is higher, and so we can treat more patients and stabilize the glaucoma in much more patients with a less invasive procedure compared to classic filtering surgery.
Carsten, always a pleasure.
Pleasure was on my side, and hope to see you soon.